Cervicogenic headache is response to manipulation related to frequency of treatment. Chiropractors traditionally initiate high-frequency care for all new patients regardless of complaint based on an acceptance that any biomechanical or neurological changes imposed by manipulation or other approaches tends to regress quickly unless it is frequently reapplied as reinforcement. Yet this is hypothetical and externally may be viewed as self-serving. Little research has addressed the value of higher frequency care compared to lower frequency care. Mitch Haas et al. Has published on this topic for both low back pain and cervicogenic headache. The initial publications were small studies, but more recently larger studies, first for the low back and now for cervicogenic headache, have been performed. The title is Dose Response and Efficacy of Spinal Manipulation for Care of Cervicogenic Headache, a dual-center randomized controlled trial published in the Spine Journal in 2018. His earlier study was published in 2010 in the Spine Journal entitled Dose Response and Efficacy of Spinal Manipulation for Chronic Cervicogenic Headache, a pilot randomized controlled trial. This small study involved 24 adults with chronic cervicogenic headache who were randomly allocated to 1, 3, or 4 visits per week for 3 weeks. High-velocity, low-amplitude adjusting was performed, and DCs could also apply up to 2 physical modalities at each visit, such as heat and soft tissue therapy. At 4 weeks, there was an advantage for 3 or 4 visits per week, and this advantage increased at a 12-week follow-up, meaning those that were treated more frequently had a sustained effect above those treated less frequently. So the obvious question, what is cervicogenic headache? It's not a specific ICD-10 diagnosis, but is classified only by the International Headache Society, who have established the diagnostic criteria. Cervicogenic headache is defined as a secondary headache related to a neck disorder. The point prevalence ranges from 0.4% to 4.6% and is found in up to 18% of the chronic headache population. Specifically, the cervicogenic headache diagnostic criteria include A. Pain referred from a source in the neck and perceived in one or more regions of the head and/or face and fulfilling criteria C and D. B. Clinical laboratory and/or imaging evidence of a disorder or lesion within the cervical spine or soft tissue of the neck known to be or generally accepted as a valid cause of headache. C. Evidence that the pain can be attributed to the neck disorder or lesion based on at least one of the following. 1. Determination of clinical signs that implicate a source of pain in the neck, and 2, abolition of headache following diagnostic blockade of a cervical structure or its nerve supply using placebo or other adequate control, and D, pain resolves within 3 months after successful treatment of the causative disorder or lesion. An inclusion-specific criteria for B and C were the cervicogenic headache involves pain in the neck or suboccipital area but may radiate. Pain is provoked or aggravated by specific head movements, and one of the following is evident: restricted neck movement, changes in muscle contour or response to stretching and contraction, or abnormal tenderness in muscle. And radiologic evaluation may demonstrate changes in the cervical curve or movement abnormalities on flexion-extension views. This current study was an open-label, randomized controlled trial conducted in Portland, Oregon, and Minneapolis, Minnesota, a coordinated effort between University of Western States and Northwestern University of Health Sciences. 256 participants with chronic cervicogenic headache were randomized, half at each site, to one of 4 dose levels of spinal manipulative therapy. All participants were scheduled for 18 visits over 6 weeks. Participants were randomly assigned to 0, 6, 12, or 18 visits for SMT. They received a brief light massage at all remaining visits to control for provider attention and touch. Follow-up was by headache diary and mailed questionnaire at 6, 12, 24, 39, and 52 weeks. Data gathering from participants was web-based. They used a short message service, or SMS, or email for delivery and completion of daily electronic headache diaries. Paper backup was also allowed. Measurement of 7 participant characteristics included cervicogenic headache days, cervicogenic headache pain intensity, gender, age, differential confidence in success of SMT and massage control, previous SMT or massage for cervicogenic care, and tension-type headaches. The primary outcome was cervicogenic headache frequency, which was indicated by the number of days with cervicogenic headache in the prior 4 weeks at the 2 follow-up periods. In other words, participants were asked at 12 weeks, in the past 4 weeks, how many days did you have a headache? And then this was repeated at the 24-week follow-up. Diaries and questionnaires were completed without any influence by study personnel, and providers had no access to these documents. Secondary outcomes were average cervicogenic headache pain intensity computed from the daily diary entries for days with cervicogenic headache, and using recall backup from participant questionnaires using the standard numerical rating scale. This approach is recommended by the International Headache Society. And other measures were the Headache Impact Test for Headache Disability, Quality of Life using the EuroQual 5D, Global Improvement, Days with neck pain and neck pain intensity, and satisfaction with a 7-point Likert scale on certitude of treatment success, and a 6-point Likert scale ranging from very dissatisfied to very satisfied with care. The treatment visit was a 10-minute visit consisting of, in the first 5 minutes, the treating chiropractors conducting a brief history and recording any adverse effects of care and applying a hot pack, and the second 5 minutes when a brief examination and SMT or the light massage control were performed. A unique feature was protocol standardization, including what they call provider equipoise. This was monitored through office observation by a chiropractor who was part of the study team and a participant questionnaire. In other words, was the provider as enthusiastic or engaged equally at each visit? During the treatment phase, a board of over-the-counter analgesics were allowed. Any other care for cervicogenic headache was discouraged. There were no restrictions to care after completion of the 6 weeks of the study intervention period, although follow-up indicated little care and no difference among groups. It's important to note the researchers' criteria cutoff point for the indication of a minimal clinically important change. The number of cervicogenic days, the primary outcome measure, was dichotomized using a 30% and a 50% improvement threshold. A 30% improvement was considered the threshold for a minimal clinically important change. Regarding compliance, the percentages of participants attending at least 14 of the 18 treatment sessions were 92% in the 0 SMT group and 97% in the 18 SMT group, respectively. Compliance with follow-up data collection was greater than 89% at all time points for the 3 SMT groups. It was similar in the control group in the short term, but decreased to 82% in the long term starting at 24 weeks. Let's review some of the baseline means. Participants reported a mean of 15.6 days for 4 weeks with cervicogenic headache, approximately 4 days per week, and 18.3 days per 4 weeks with neck pain. And there was a mean duration of 7.3 years for cervicogenic headache. Now to the results. Cervicogenic headache days were reduced by about 1/3 for the control group, and about 1/2, or up to about 8 days per month, for the 18 SMT visit group. So there was a treatment effect for the light massage group, just not as strong as for the high-frequency SMT group. There was a reduction of approximately 1 cervicogenic headache day in the prior 4 weeks for each additional 6 visits for spinal manipulation, which calculates to an additional 5 to 11% of participants becoming responders per additional 6 SMT visits. SMT was most beneficial compared to the minimal massage control with the 18 SMT visit group at all time points. The mean difference comparing 18 SMT visits with the control were a negative 3.3 cervicogenic headache days and a negative 2.9 cervicogenic headache days in the previous 4 weeks for the 12 and 24-week follow-ups, respectively. and a negative 2.8 cervicogenic headache days over all follow-ups in the longitudinal profiles. Although over half of participants in each group attained 30% reduction in cervicogenic headache days by 24 weeks, earlier attainment occurred for the higher dose groups only. Less than half of participants in each group reported at least 50% reduction in cervicogenic headache days, with the exception of the highest dose group. Headache and neck pain intensity and medication use did not seem to differ among groups. In evaluating mild or moderate treatment-related adverse events, these were much more frequent among the SMT groups. However, there were no serious adverse events. So the question remains, why are the effect size differences not larger between SMT and light massage? Is it the interaction with the doctor that is the common thread, or the expectation for improvement? So let's summarize. Although additional SMT treatments resulted in fewer headache days in the past 4 weeks when compared to light massage, this was mainly true only for the high-frequency group at 18. 6 SMT visits had similar outcomes to the no SMT control, and 12 SMT visits demonstrated some advantage over the control. However, comparisons were not statistically significant. The diagnosis of cervicogenic headache is both an exclusion diagnosis, meaning other headaches have been ruled out, and also an overlap diagnosis, meaning individuals could have, for example, muscle tenderness and pain with neck movement with migraine headaches. In fact, 75% of migraine patients have neck pain. So the obvious question, given past studies indicate some success with migraine headaches utilizing manipulation, is cervicogenic a pure diagnosis? And given chiropractors use the same approach for all headache patients regardless of whether the diagnosis is migraine, tension, or cervicogenic, are we testing manipulation for its effectiveness for cervical causes only when we narrow it down to what is often a subjective diagnosis of cervicogenic? Also, recall that with the exclusion of other headaches, the primary ones, migraine and tension type, there is no actual clinical test for either. The diagnosis is entirely based on history. Cervicogenic does have objective indicators based on exam and radiographs, but are these exclusive to cervicogenic, or is this an implied exclusive relationship? Cervicogenic is likely a post-treatment diagnosis, meaning if the cause is cervicogenic, it will likely respond more than those that are not, at least hypothetically. So to summarize, this is a well-designed and executed study and is valuable in determining frequency of care for cervicogenic headache. The questions still in need of answering are, is the patient-doctor encounter the primary determinant and not the specific treatment? Is cervicogenic simply those post-treatment that respond to manipulation? And how does that intersect with the traditional criteria for other headaches, such as migraine and tension type?